Welcome, everybody, and thank you for joining our webinar this afternoon. My name is Katie Vollrath, and I'm the TCD Clinical Specialist with Natus Neurology. Today's topic is vasomotor reactivity testing. I am pleased to be hosting today's session in conjunction with our education team. In a moment, I'm going to introduce you to our speaker and presenter and more, but first, I need to go over a few housekeeping items. Today's session is being broadcast across the Internet, which means the presentation can be heard through your Internet speakers. If at any point you experience any technical issues, you can try to exit the session and rejoin it using the same links and email information you originally used. I'm also joined by my colleague, Erin Solier, who is listed as the host in your web panel. Please feel free to send her any questions if you have technical issues. During the presentation, I encourage you to write down and submit any questions you may have for Ann using the WebEx chat box to either myself or the WebEx host. I will be moderating all the questions at the end of the session after a brief pause. Now, I would like to introduce today's speaker, Ann Moore. Ann has been active in the vascular field since 1984 and has worked at Harborview Medical Center in Seattle since 1994. Currently, she is the cerebral vascular supervisor at Harborview Lab. Ann has a plethora of TCD experiences in a wide variety of pathologies and has contributed to many scientific publications regarding TCD and other vascular ultrasound applications. She was one of our past webinar speakers this past March when she addressed the subject of TCD technique and tips. Her presentation was enthusiastically received with rave reviews from all attendees. We welcome Ann today. Ann, I will now turn this over to you.
Thank you, Katie, for that very nice introduction. So, in order to understand vasomotor reactivity testing, we need to understand the concept of cerebral autoregulation. And cerebral autoregulation was actually observed in the late 1930s by Fogg, who observed vessel caliber changes in Peel vessels in cats while he manipulated the perfusion pressures. And he suggested that these vasomotor reactions probably had a role in blood flow regulation. So we define cerebral autoregulation as the ability of the brain to maintain constant cerebral blood flow despite changes in arterial blood pressure. You may have already seen this slide. It is the autoregulation curve. On the horizontal axis, we see blood pressure in mean arterial, and the vertical axis is cerebral blood flow. So as you can see, the brain maintains blood at a constant level between 50 and 150 mean arterial pressure. But beyond 150, the microcirculation will compensate by trying to vasoconstrict. But because of increased flow from the increased blood pressure, the mechanism eventually will fail. And what we see then is vasogenic edema and hemorrhagic stroke. On the opposite end, below 50 mean arterial pressure, we see that the perfusion pressure is too low. So the microcirculation will vasodilate to compensate, but eventually the mechanism will fail, and then we see arterial collapse and ischemic strokes. So between 50 and 150 mean arterial pressure, with activity, we'll see an increase in blood pressure and heart rate, as well as cerebral blood flow will increase. And the brain says, oh, I've got plenty of blood. And so it regulates this by vasoconstricting the microcirculation. And conversely, as we sleep, blood pressure and heart rate will decrease. And the brain says, well, I may not be getting enough blood flow. And so again, the brain will regulate by vasodilating the microcirculation. So there's a couple of things that will affect cerebral autoregulation. There's metabolic demands, which is O2 consumption and nutrition for the brain, myogenic mechanisms such as the muscle contractions, the vasodilation, the vasoconstriction, and neurogenic mechanisms such as sympathetic nerve responses. But what I'm going to focus on today is how CO2 levels affect cerebral autoregulation. Now, CO2 is a powerful vasodilator and vasoconstrictor of the intracranial microcirculation. High levels of CO2 will cause an increase in cerebral blood flow, and low levels of CO2 will cause a decrease in cerebral blood flow. If it's available to you, it's good to know what your patient's CO2 level is, whether it's an end tidal or even a blood gas level, because low CO2 levels may actually accelerate cerebral autoregulation, and high levels of CO2 will impair cerebral autoregulation. So vasomotor reactivity measures the response of a hypercapnic challenge by the increase in TCD flow velocities. And we can do these tests by breath-holding exams, administering CO2, but it's always mixed with oxygen, and the administration of acetazolamide. I'm going to focus on breath-holding exams and CO2 challenge tests. To understand how we can use TCD to test vasomotor reactivity, you need to understand that when CO2 levels increase, it vasodilates the microcirculation, which then is reflected in the intracranial vessels, the major intracranial vessels here. Here I've said middle cerebral artery velocities will increase because I have a diagram of the MCA on the right-hand side. And then conversely, low CO2 levels will vasoconstrict the microcirculation, which again is reflected as decreased velocities in those intracranial vessels. So here's an example of normocapnia, if you will, with a normal MCA flow velocity. And when we see the microcirculation dilate, as you can see in this middle segment, MCA flow velocities increase. And again, with vasoconstriction of the microcirculation, then we see a decrease in MCA flow velocities. Now, in order to do breath holding, you do need a cooperative patient. You monitor the bilateral middle cerebral arteries. The patient is asked to hold their breath for 30 seconds. We record the MCA baseline velocities at the beginning of the study and then at the end of the 30 seconds. And what you get is a breath holding index, and that is calculated by taking the mean flow velocity during apnea minus mean flow velocity at rest, divided by the mean flow velocity at rest times the amount of seconds the patient was able to hold their breath. And the normal value is greater than or equal to 0.69. Here's a nice example of a normal breath holding test. We see the bilateral middle cerebral arteries are monitored, and here is an example of the middle cerebral artery on the right side at the beginning of the test and then at the end of the test. Notice the increase in end diastole. Below, we see how the sonar will calculate the change in velocity. We see it go from 49 to 98, and the percent change is 98%. Now, there's a decrease in the pulsatility indice from 1.39 to 0.79, or 49% decrease, and that's just because end diastole has increased. We see the similar findings in the left MCA, And as you notice, the breath holding index is 3.4 on the right and 3.3 on the left, which is normal. So this is an easy, convenient way to test for hypercapnia response. It's not technical. There's no need for CO2 and O2 tanks, end-tidal monitoring equipment, and most patients can tolerate it. But it can be difficult for older patients to hold their breath for 30 seconds, and sometimes you may need to repeat the exam several times for accurate results. It does only test for hypercapnia, and you cannot measure end-tidals during the test. And a CO2 challenge is a study that will administer the gas mixture of CO2 mixed with O2. And CO2 will maximally dilate the microcirculation, and that's important to remember. So some of the contradictions for doing a CO2 exam is that if patients have severe COPD or they have a baseline end-tidal CO2 of 46 or more, and maybe they're unstable, have an unstable cardiac condition, they should not be tested. So if the mean arterial pressure for the patient is above 120 or 200 systolic, the patient, again, should not be tested. And this is why it's important to remember that CO2 will maximally dilate the microcirculation, and blood pressure will increase to compensate for that dilation. So you don't want your patient to start off hypertensive, and that's why we have these guidelines in place. So just like a breath-holding exam, patients that can't follow directions, certainly it would be very difficult to test because they need to hold a tight seal with their lips around a mouthpiece, and they need to follow your directions to hyperventilate for the hypocapnia part of the test. So we'll monitor the bilateral MCAs or the bilateral PCAs depending upon where the pathology is. We use a non-rebreather T-piece with one-way Rudolph valves. We have a capnograph to measure end-tidal CO2, and nose clips so that the patient remembers to breathe in and out only through the mouthpiece in their mouth. We use the gas mixture of CO2 and O2. We actually have two concentrations. We begin with a 5% CO2, and if we don't see a 10-point increase from the baseline CO2 of the patient, then we'll switch to 6% CO2. We use a mylar balloon as a reservoir for the gas, and we test our patients sitting up because we want the lungs to fully expand as they take nice, slow, deep breaths and breathing in the gas. So we'll document the baseline MCA velocities, end-tidal CO2, and mean arterial pressure. We have the patient inhale the gas mixture for 3 minutes, and then we retake vitals and document again MCA flow velocities and end-tidal. And we give them about a minute to rest and kind of catch their breath. We'll ask the patient to hyperventilate, and we do that with the patient so that when we start getting a little lightheaded, then we know our patient's getting lightheaded. We like to see that end-tidal go below 30, but certainly not below 25. And one last time, we take the vitals and document MCA flow velocities and end-tidal CO2 for calculations. And here is the calculation for vasomotor reactivity. It was published in 1988 by Rinkelstein, and it's still very useful today. Here are the normal values as well as the 3 categories of abnormal values. But we also calculate the percent change in velocity per millimeter of CO2. And I'm just going to show you down here and that calculation is the total VMR divided by the hypercapnia end tidal CO2 minus hypocapnia end tidal CO2. And the reason why we do that is because if this percent is 3% or more, the test is considered normal. So even if your VMR calculates out to mild to moderately reduced, and you get this percent change in velocity per millimeter of mercury of CO2 at 3%, then the test is considered normal. So CO2 challenge test is pretty technical. You do need to coach your patient throughout the exam, especially when they're breathing in that CO2. They've got a nose clip on their nose, which could be pretty uncomfortable. They're breathing in this gas mixture and it tastes dry. And because it's a high percentage of CO2, their brain is saying, I'm not getting enough oxygen. So we always tell our patients you're getting plenty of oxygen. It's actually a higher percentage than what they're breathing, what we breathe in the atmosphere. But the brain will compensate, and they start to breathe a little quicker and they start to hyperventilate. So the CO2 test will test hypercapnia and hypocapnia, and it does report a total VMR response. So why do we do this to our patients? Well, vasomotor reactivity can become impaired when there's a 70% stenosis or greater, whether it's extracranial to the circle of Willis or even an intracranial vessel, such as a significant MCA stenosis. If a patient has small vessel disease, well, that's where all the action occurs in the microcirculation for vasodilation and vasoconstriction. And if this is diseased with arteriosclerosis, then there certainly can be impairment there. So I'd like to share with you 3 case studies that we feel that CO2 challenge was very beneficial in clinically deciding care for these patients. This is a 45-year-old male who presents with a history of stroke several months ago. He had a traumatic brain injury 27 years ago, and with injury to his right orbit and face requiring multiple surgeries and craniotomies involving the right frontal and temporal lobes. Since his stroke, he continued to have left arm and hand numbness, as well as limb shaking episodes. So we did a transcranial Doppler on him, and this is the right side. The ophthalmics were antegrade. We see the siphon, terminal ICA, and ACA were fairly normal, but what you see on the right MCA is low velocities, especially here are the depths, here's the velocities, especially at a depth of 40 where it's 25. On the left side in the MCA, we see a low velocity at a depth of 54. However, this could be probably due to angle of insonation. The extracranial right ICA was not insonated because it was known to be occluded. So we did not calculate our ratios. What we also see on the right is the P1 and P2 segments are elevated. And this is because it's trying to bring blood up to the distal right MCA territory. So we were asked to do a CO2 challenge. And he, on room air, his end tidal CO2 was 46. And what we see is the mean, the time average mean of the right MCA being 35. But what's most noted is the slowed systolic upstroke in the right MCA, which we all know is consistent with a hemodynamic lesion proximally. On the left side, we see the velocity is 40, and we see a beautiful straight upstroke. So we administered 5% CO2 and O2 for 3 minutes. and he became hypercapnic with end-tidal CO2 of 57, so a nice increase. Interestingly, though, he went from 35 to 34 in his right MCA, which is what we call a paradoxical effect, because it was supposed to increase like the left side did and went from 40 to 66. So this is the thought behind this is that this is a steal phenomenon, that the normal side is actually stealing blood from the abnormal side. And then we had him hyperventilate for 1 minute, and his end-tidal CO2 went to 28. We can see that the microcirculation on both sides vasoconstricted as it was reflected in decreased velocities in the bilateral MCA. So after we calculated out his VMR, we see that the left MCA was 76, which was normal, and the right MCA was 14%, which was exhausted. He had an arteriogram that confirmed the right ICA occlusion, and so he went for revascularization surgery. He had an extracranial to MCA radial artery bypass, and his limb shaking TIA ceased. This is an angiogram of that bypass graft. We see the common carotid, the external carotid, and this is the anastomotic site of the radial artery from the external carotid. And here is the graft. It's tunneled underneath the skin. There's a burr hole that then is placed, done into the skull, and then it's anastomosed to the M1 segment. And what you see is nice filling of the MCA territory. And because this is a high flow graft, the MCA actually reverses flow, and the patient did very well. So our next case is a 45-year-old female with a history of hypertension and known severe left MCA stenosis. She presented with a recent syncopal event and transient right-sided numbness and right lower extremity weakness. She attributes her symptoms from becoming dehydrated, but then she had no further symptoms. So her TCD demonstrated elevations in the bilateral ACAs as well as in her right MCA. We see velocities of 127. Noting the left MCA, we see low velocities, and because these were complex collaterals, we felt that the MCA was occluded. Interestingly, this is the P1 segment on the left was not incubated, which was consistent with a fetal origin. The P1 segment is actually absent in these with a fetal origin, and the P2 segment is being fed by the left internal carotid, which again is elevated to try to bring some flow out to the distal left MCA territory. Her right vertebral is hesitant, and so that's why we took the bilateral blood pressures, and we see there's no gradient. So we felt that this was due to a non-dominant vertebral. An MRA confirmed the left MCA occlusion as well as the non-dominant vertebral. So we were asked to do a CO2 challenge on her, and her left MCA VMR was 68%, and her right was 67%. Now, the low normal is 70%. So she was actually mild to moderately reduced in her bilateral middle cerebral arteries. She continued to be asymptomatic, and she actually had a consultation with neurosurgery for possible bypass, which is on hold for now. This is her arteriogram on the left side. This is the left internal carotid coming all the way up. We see the terminal ICA, and then this is the ACA, which looks really well, but what we don't see is a left MCA. branch is the fetal origin PCA. This is a left vertebral injection. On the right-hand side, we see some backfilling of the right vertebral, again demonstrating that non-dominant vessel. And as we follow the basilar, this is the P1 segment on the right, and we see that the P1 segment on the left is absent. Again, consistent with the fetal origin. And lastly, we have a 44-year-old female, right-handed, with a history of diabetes and high blood pressure. She had multiple infarcts and was admitted and discharged several times over about 2 weeks. An MRI showed infarcts in her right frontal lobe, her left frontal lobe, mild chronic microvascular ischemic changes, and small old bilateral basal ganglion lacunar infarcts. So she was transferred to us for further workup. And now her TCD showed antegrade ophthalmics. We see that the right terminal ICA was not incunated, and that the terminal on the left was elevated, as well as the bilateral ACAs. And again, what we see in the right MCA are these low velocity, they actually were slowed systolic complex collaterals, which told us that probably the MCA was occluded. On the left side, we see high velocities and a ratio over 4. So we have a significant vessel narrowing in the left side. The PCAs are suggestive of vessel narrowings as well, because we have a slowed systolic upstroke in the bilateral P2 segments, as well as elevations in the P1 segments. The elevated velocities in the distal basilar can represent collateral, but we certainly can't rule out altogether a vessel narrowing. So we did some transcranial imaging, and here you see the complex collaterals, but no MCA that we could find. And here's the slowing of the systolic upstroke. As everyone again knows, it's consistent with a proximal hemodynamic lesion. And this is her arteriogram, where we see the right ICA injection coming up to the terminal ICA, and there's no MCA. What we do see are these fragile collaterals, or what's called a puff of smoke, which is consistent with Moyamoya syndrome. On the left side is the left internal injection up to the terminal ICA, and what we see is a high-grade stenosis in that ACA. Remember, the TCD showed at velocities of 200 and a ratio of 4 and more in that left MCA. Well, it looks pretty darn good, except for the anterior temporal branch of the middle cerebral artery has a high-grade stenosis. So the TCD picked this up, and that's just a limitation of the test because of the wide sample volume. This is a left vertebral injection, and there's retrograde filling of the right vertebral. Here's the basilar, and again, it just demonstrates the P1 segments that are highly stenosed. And again, we see that we confirmed it with transcranial imaging. So we were asked to do a CO2 challenge on her because she was preoperative for emergent surgery. Her left MCA VMR was 49%, which is mild to moderately reduced. And to no surprise, her right MCA VMR was 17% or severely reduced. But the neurologist was able to give blood pressure guidelines to the surgeon, and she was able to have her surgery very safely. So we feel that vasomotor reactivity testing is useful for screening for surgical intervention. It assesses the risk of ischemic stroke because the lower the VMR, the higher the risk of stroke. It's very useful for follow-up exams. We use it for preoperative evaluations for patients with known extracranial or intracranial disease, and for patients who are allergic to acetazolamide. Sometimes we even get referrals for patients that the doctors don't want to do a CT perfusion and radiate the patient. They just would prefer a non-invasive study. And I'd like to thank everyone for joining, and if you have any questions, I'm going to turn it back over to, I think, Katie.
Well, Anne, thank you so much. Your presentation was so helpful, especially the case studies showing how vasomotor reactivity testing impacted patient care. So I'm going to open it up right now for questions. We're going to wait just a few moments and see what questions come in, and then I will ask Anne her opinion on whatever questions we get. Okay, Anne, are you ready?
I'm ready.
All right. What technical difficulties can occur when you are actually performing the VMR studies? What should people be aware of?
I think one of the most common technical difficulties is losing the signal. When the patient is breathing the CO2, sometimes even just the inhaling the gas, that if you have a very small window for intonation, you may not get the absolute highest velocity and the absolute lowest velocity. And that's why we calculate the percent change in velocity per millimeter of mercury of CO2, because if that's normal, then the test is normal.
Okay, thank you. Okay, next questions. What do you do? I assume they're saying that some patients have problem breathing in the CO2-O2 mixture with the nose clips and rebreathing. Do you have any advice for how do you coach patients through this?
Well, we're always telling them they're doing a super job. We're helping them hold the mouthpiece in their mouth. We're telling them, you know, how much time they have left. And after we administer that CO2 for 3 minutes, sometimes we just take the mouthpiece out of their mouth so that they can take a couple of breaths. So because the concentration, as I said before, the CO2 is high, and the brain is just making you think that you're not getting enough oxygen, and yet you are.
Very good. And we've got one question that is not about your subject today.
Okay.
I will give it to you, and if you can comment, fine, and if you are not prepared for that, we'll just be fine. What causes could lead to normal TCD results, and on the same day the patient goes to CTA or angio, which shows vasospasm?
Oh, well, vasospasm can occur very quickly. I've seen vasospasm occur within a 6-hour time period. So you could have a normal TCD in the morning, and then by the afternoon the patient could be crumping with neurological deficits and in severe vasospasm.
All right, thank you. That's the end of our questions. So, and again, we thank you for that lovely presentation and the many tips that you gave us regarding vasomotor reactivity testing. Our past TCD webinars are available on the Natus Neurology YouTube channel. Note you cannot receive CMEs for watching these videos as they are for reference refreshing only, but we do encourage you to use those as a library. If you subscribe to our YouTube channel, you will receive an email notification every time we add a new webinar. Find us by searching Natus Neurology on YouTube. Again, we thank you, and I would again encourage you to fill out your SurveyMonkey. Thank you very much. Bye-bye.
Thank you, Katie.